Today's SCREE seminar series speaker was Professor Ian Tomlinson, Professor of Molecular and Population Genetics at the Wellcome Trust for Human Genetics, University of Oxford. Professor Tomlinson, thank you for coming to talk to us today. Your seminar was entitled The Ultramutator Phenotype in Colorectal Cancer. Microsatellite instability has been a hallmark of roughly 10 to 15% of colorectal cancers for over 20 years. These cancers carry a high burden of small mutations and have a good prognosis in stage 2 to 3 cancer. Recently, a group of cancers with an even higher mutation burden has been described. Tell us about the discovery of these ultramutator cancers.
So there are two parallel pieces of work that led to this. One was the large-scale sequencing by a US group called TCGA of about 500 colorectal cancers, who identified a group that had a mutation burden, and these are small mutations, single base pair changes mostly, way above the ones we already knew and much higher than the microsatellite unstable burden. And we ourselves looked in the germline, so predisposition to bowel cancer and bowel polyps, and we found mutations in these two genes called poly or POLB1, and those cancers also had a very high mutation burden. And the two pieces of evidence came together really to show that these defects, which were in the proofreading or the repair components of these two enzymes encoded by poly or POLB1, were leading to this very high number of mutations in the cancers, which presumably contributed importantly to the growth.
Tell us, what are the clinical features of these ultramutators?
So a lot of them are grossly similar to any bowel cancer that you may see, and the polyps the patients get look quite similar to normal adenomas in most cases. But what we think is that the patients who have these mutations are probably in some ways fortunate in that their prognosis is better than most bowel cancer patients. It's hard to prove this absolutely because the numbers involved are not that great in even a relatively large clinical trial, but the evidence is accumulating that that is the case. And if these patients do well, we may be able to spare them some treatments or give them alternative treatments if they do need that sort of therapy.
In a way that's sort of answered, what is the importance of identifying them amongst the more common types of colorectal cancers?
So yes, that's right, what I've just said it applies to that. I think also that more generally the future lies in identifying these groups of patients that we can give, if not individual therapy to, we can treat them as special groups, and we will know after a lot of work that these people will either respond very well or not need so much treatment. Another group may need their own special treatment, and do this so we might end up with 20 or 30 groups of bowel cancer patients, each of whom are treated with their own specialised treatment regimen.
Well, thank you, Professor Tomlinson, and thank you for giving such a great talk.
Thank you.